In fact, during this COVID time, our connectivity online or virtually has been even more as compared to our physical connectivity during the non-COVID times. And today we'll be discussing about a really promising combination, that is a combination of an SGLT2 inhibitor and a DPP4 inhibitor, and more so not in the context of glycemic control, because we know that all the American Diabetic Association and European Association for Study of Diabetes, all recommendations have now shifted towards combination of anti-diabetic agents to achieve better glycemic control. But today we'll not give more focus on the overall glycemic target, but the focus will be on a better target organ protection. So besides the glycemic control, are we going to achieve a better glycemic control along with better organ protection? So that's the main context. So that's why the topic has been named as connecting dots of heart, kidney and vessels. Now, when we think of vessels, we know diabetes produces its major organ damage by two types of involvement of vessels. One is microvascular complications or involving small vessels. Another is macrovascular complication or involvement of large vessels. And both these type of microvascular as well as macrovascular complications affect two most vital organs of the body, that is heart and kidney. So we'll see how the dots are connected as regards heart, kidney and vessels. And we know that there is a complex interplay of cardiovascular disease and type 2 diabetes. That is, there is both a contribution of microvascular as well as macrovascular. And anybody who has developed a type 1 or type 2 diabetes has a substantially higher CV risk, that is a 3-fold higher fatal CV event. And as per Wang's data, which got published in 2016, almost 2 out of every 3 deaths in a patient of type 2 diabetes is accountable to CVD. The coexistence of the traditional risk factors. What are the traditional risk factors? Like age or increasing age, smoking or tobacco use, dyslipidemia or hypercholesterolemia and hypertension. They have a clustering impact and they only augment the cardiovascular risk. And atherosclerotic cardiovascular disease occurs almost 1.5 decades earlier in the presence of type 2 diabetes. What does it mean? Suppose a person who doesn't have diabetes is likely to develop a cardiovascular complication at the age of 65 years. If he develops diabetes, his likelihood of developing such a complication comes down to 50 years. So it's almost certain or brought in earlier by almost 15 years. And in the Framingham upscaling study, that's a quite a prolonged, horizontal and prospective study. It has found that 70% of patients with diabetes were found to harbor subclinical cardiovascular disease. And that is primarily because of dysglycemic legacy. Legacy means, suppose we have an abnormal glycemic parameter now, but the adverse effects may not be just confined to the problems that we are going to face now. The problems may be subsequently found after years, even after decades. That is called a dysglycemic legacy. So if you have a poor HbA1c control in the first year of diagnosis, you could have increased long-term complications. And as you see in this curve, the drive risk for complications. The variation could be so minimal in the beginning, but as you go more and more towards say 5 years and above, that's around say 60 months and above, you could find the risk of these complications substantially increase. The risk of myocardial infarction, stroke, heart failure, and composite cardiovascular events. So more than 5 years down the line, you could get the adverse effects. And that is why more than 20% of patients with type 2 diabetes mellitus, they are diagnosed with heart failure, which also increases mortality and morbidity, and it is contributed by coronary artery disease, hypertension, and diabetic cardiomyopathy. So it's not just a single approach, but multiple approaches can lead to increased incidence of heart failure. And if we see a person who is non-diabetic versus a similar age person who becomes diabetic, his life expectancy is reduced by almost a decade. To be actual, the calculations have suggested 12 years, but we can say almost a decade. So this is from more than 1.35 lakh deaths which has been found in patients of diabetes, and this is a pretty long follow-up of almost 13 years. So this reduced life expectancy is because of the cardiometabolic multimorbidity, which produces diabetes along with stroke and or myocardial infarction. And besides the heart, another significant cause of morbidity in patients of long-standing type 2 diabetes are chronic kidney disease. Now, CKD remains an insufficiently addressed complications of type 2 diabetes. What does it mean? People are not concerned about the CKD related complications unless they find an overt rise in say serum creatinine or a substantial decline in the urine output. We must not forget that a CKD progresses in 5 stages, and whenever we find these telltale evidences, that's towards when a person progresses beyond stage 3A or stage 3B. But earlier than that, if you can actually detect them, then you can prevent these deadly complications. So coexistent of CKD and diabetes mellitus are increased risk of mortality, and subnormal EGFR emerged as a strong predictor of major CV events. Many of the patients who have diabetic kidney disease will ultimately die due to heart attack or heart failure. That is why they are highly vulnerable population in whom our risk assessment should be more aggressive. So CKD is associated with almost 1.5-fold greater risk of major vascular events. Now, this is the different types of heart failure, because we know broadly heart failure can be classified into 2 types depending on the person's ejection fraction. When the ejection fraction is more than 50%, it's called heart failure with preserved ejection fraction, and when it is less than 40%, less than 50%, earlier it was called as heart failure with reduced ejection fraction. Now another entity has come in where mid-range ejection fraction is being considered, that is between 40 to 50%. So prevalence of heart failure is almost 1/4 to 30%. So 25% of overall patients. And another very important thing is 40 to 50% of them, they tend to get hospitalized. Why it is important? Because we know in India, the cost of hospitalization may not be that high, but in Western countries, every time a patient gets hospitalized, the cost substantially increases. So type 2 patients who have an elevated risk of developing these type of complications, we should try to achieve a better control of these endpoints. Now, the important endpoints are considered as MACE, or major adverse cardiac events. Now, what are the major adverse cardiac events? Death, myocardial infarction, and another vascular event, that is a stroke or cerebrovascular event. And recently, another thing which has become really important in long-term management of diabetic patients, that is not something a mortality parameter, but it is a morbidity parameter. Now that is called HHF, or hospitalization due to heart failure. So a person having an episode of heart failure which requires admission to hospital, so that's called hospitalization due to heart failure. So on an average, patients who have type 2 diabetes mellitus have almost 50%, you can say 45% increase in risk of hospitalization to hospitalization for heart failure, despite other major risk factors which are in the guideline recommended range. So if we keep their lipids under control or blood pressure under control, and they don't smoke, so these are the three important parameters. If these things are kept under control, still the incidence of hospitalization due to heart failure increases. So diabetes can lead to heart failure through both atherosclerotic dependent and independent mechanisms. What do you mean by that? If a person develops atherosclerosis, that can lead to ischemic heart disease or coronary artery disease, and subsequently that can produce heart failure. But some patients may develop heart failure de novo in type 2 diabetes mellitus without having actually ischemic heart disease, which was earlier entailed as an entity known as diabetic cardiomyopathy. So they could have atherosclerotic mediated, that is through like myocardial infarction or other types of acute coronary syndrome. Then there are other modalities which are atherosclerosis independent. They do not depend on exactly atherosclerotic manifestations, and these are due to direct inflammatory microvascular effects on the myocardium. Those are adverse effects of hyperglycemia. So if your glycemic status is not optimally controlled, that can lead to microvascular dysfunctions or endothelial dysfunction in microvessels of the heart, which can ultimately lead to heart failure. Then we find an important link between kidney and heart, more so in patients of diabetes mellitus. So this is called renal cardiac link. So if you have a kidney problem due to diabetes, it can lead to subsequently heart failure. And if you have heart failure, your chance of preserving the renal blood flow is at risk. And if you have a decreased renal blood flow, that can affect the kidney. So they are interlinked. And another important thing that we find, that in CKD patients, the CV death or cardiovascular related death is substantially high. So these patients landing up with end-stage renal disease or cardiovascular death, the two deadly endpoints from kidney and heart side, are definitely increased in patients of type 2 diabetes mellitus once the duration of diabetes is more than 5 years. So microvascular complications can be one of the important indicators to see whether the person has a high risk of developing these deadly complications. And one important parameter is microalbuminuria. So we can assess the microalbumin and find that if it is a graded increasing in amount, the risk of a person developing kidney or heart related complication is also increasing. And this has also a very good correlation with retinopathy, because we know that retinopathy is also produced due to microvascular complications. So the key assessment is, if you have an untreated hyperglycemia during the 4 to 7 years between actual onset and the clinical diagnosis, then that is producing all these long-term complications as a legacy effect. So the glucose lowering efforts have been more and more aggressive over a span of, you can say, a decade. So starting from 2013, when we have discussed, we had quite an important sort of trials coming from DPP4 inhibitors like sabatemi with saxagliptin and the other DPP4 trials, to the latest CVOTs which have come out in 2020, and more so with heart failure related indications. The two most important trials which have come up with heart failure related indications have been with two SGLT2 inhibitors, with dapagliflozin, the DAPA-HF trial, and with empagliflozin, the Emperor reduced trial. So the evolution has been over a span of almost a decade, and initially we find there are quite a good number of studies with DPP4 inhibitors which were found to be cardiovascular neutral, and the subsequent upcoming of SGLT2 trials which have proven that definitely benefit of hospitalization due to heart failure is considered. So yes, by this, yes. So how does the group benefit reducing hospitalization glucose reabsorption in the convoluted tubules, reduce the renal glucose reabsorption? That means more of the glucose will be sent to the urine, and glucose, whenever it passes to the urine, will also take water along with it. So basically they will reduce the water content in the body, and we know that increasing water volume or the circulating water volume is one important cause of. Yes. So before the empiric, there are so many studies which have proven to be cardiovascular neutral, but empiric outcome is the first trial which show that these oral anti-diabetic agents can have actually substantial benefit in cardiovascular patients. So that is something which is very unique to empagliflozin, or for that matter to SGLT2 inhibitor. And subsequently similar sort of benefits, maybe in different quantity, was found in other SGLT2 inhibitors, like Canvas was done with dapagliflozin, and with etugliflozin trial also the CVOT indications are found to be helpful. Now just to have an idea, whenever we think of the SGLT2 inhibitor trials, why the cardiovascular outcomes are so significant? It's because these trials have included patients who have history of prior heart disease. So it's not just about safety, it is also important about providing benefit in patients who are already known to have cardiovascular disease. So what was done is they were given empagliflozin, and empagliflozin was given in two doses, that is 10 milligram and 25 milligram, versus the other group receiving placebo. Now, what they found, the primary outcome and the cardiovascular death and the total mortality was substantially better. So the overall outcome in patients who are on empagliflozin, be it in a dose of 10 milligram or 25 milligram, is substantially better than placebo group. And in fact, following their publication, all international guidelines on diabetes brought in them as almost a starting medication like metformin if a person has pre-existing cardiovascular disease. So if we see the actual outcomes, the 3-point MACE, that is cardiovascular death, hospitalization due to heart failure, and myocardial infarction, is reduced by 14%. Only CV death reduced by 38%, and all-cause mortality, means death due to cardiac as well as non-cardiac cause, 32%. And heart failure hospitalization is the single most driver of the substantial benefit that a patient gets. That's reduced by 35%. And worsening nephropathy. So first time an indication was that it could in fact help in protecting the kidney. So that was found in almost 40% of patients. So if we consider the benefits of empagliflozin, that is, it has benefit in preload and afterload, in the myocardial energetics. So that is by switching from different substrates to a more helpful substrates. That is switch occurring between free fatty acid, glucose, and ketone bodies, and reverse cardiac remodeling, and improving the LV function in terms of improving the ejection fraction. So if we see the three landmark trials from three SGLT2 inhibitors, that is EMPEREG outcome with empagliflozin, CANVAS program with canagliflozin, and DYSGLYCEMIC with dapagliflozin, one thing is everybody has shown that reduction of hospitalization to heart failure is across the board. But if we think of reduction of cardiovascular death, that is substantial with empagliflozin, not so substantial with CANVAS and DYSGLYCEMIC. And when we come to the composite, then that has become significant with both EMPEREG and CANVAS. And another very important thing, because we are trying to combine the dots between heart, kidney, and the glycemic status, the kidney outcomes have also been quite uniform across the three trials. So beneficial effects of SGLT2 inhibition in heart failure are this is seen in non-diabetic patients as well, and these are established already. We have suggested the trials have been DAPA-HF with dapagliflozin and EMPEROR reduced with empagliflozin. So how the hospitalization due to heart failure, if we look at the curves, then if you start giving the drug, then very early, that means almost at the end of 1 to 2 months, there is a benefit, and this benefit continues to increase as you go on continuing with these medications for more and more duration of time. So This is quite a robust thing. And if we see in this forest curve that all the SGLT2 inhibitors like empiric outcome, declarative canvas, the curves are substantial to the left of 0. That means all of them favor the SGLT2 inhibitor. So far as hospitalization due to heart failure. And similar is also with the kidney related benefits or the renal outcome. We see almost all the dots are to the left of the center. That means they are definitely going to provide benefit to persons who take these SGLT2 inhibitors. And when you have a composite of renal outcome, the composite of renal outcome has also been found with heart protection outcomes. So cardio-renal outcomes have been substantiated in the SGLT2 inhibitor. So the guidelines actually got changed because of these robust outcomes. So if a person has previously atherosclerotic cardiovascular disease, or he has indicators of high risk, or he has established kidney disease. That means if he has heart disease or kidney disease, or he is at a high risk of developing heart disease or kidney disease, then the SGLT2 inhibitors and the DPP4 inhibitors may be combined in eligible patients when the glycemic target is not optimal. So these patients in whom the glycemic targets are on the high, they have a more chance or a more risk of having a legacy effect of a bad outcomes related to heart or kidney. So they should be more optimally protected cardiovascular and renal protective, or renal cardiac friendly and neutral. So a combination of SGLT2 inhibitor and DPP4 inhibitors are brought into picture. So these are indications we see in the guidelines in a person who is drug naive. So drug naive means he has not taken any medicine. And the second group is on metformin. So he is on a first line drug, and we know the first line drug is metformin. So what they suggest is, if a person has atherosclerotic cardiovascular disease or he has very high cardiovascular risk, then you get the maximum benefit with SGLT2 inhibitor or GLP-1 analog. GLP-1 analog are of course interested to take GLP-1 analogs. But if they are interested to take a tablet or an oral form, then you could go in for SGLT2 inhibitor. So in this group, metformin is no longer the only first line therapy. You could think of both metformin or even this class of agents which provide definite positive outcomes in cardiovascular and renal endpoints. So initially these recommendations were only for atherosclerotic cardiovascular disease or heart disease. Now the extension has gone into even CKD. So if a person has chronic kidney disease or at risk or with obvious chronic kidney disease, maybe in stage 1 or stage 2, and he is not optimally achieving the glycemic control status, that is SpA1C is more than 6.5, then you could also think of combining the SGLT2 inhibitors or DPP4 inhibitors. Now, after the cardiovascular data, even the kidney related data was also quite significant when we compare the different combinations of SGLT2 inhibitor with DPP4 inhibitor. The first was the Carmelina. So Carmelina had a very positive impact on use of linagliptin, and we know that linagliptin has a very important advantage of being used in patients with advanced CKD. So the concept of using empagliflozin and linagliptin to give more benefit in terms of heart and kidney was initially uh, proposed, and subsequently it had to be substantiated by outcomes. So then came Carmelina, which assessed the cardiovascular safety and clinical outcome. And we know that it is an important study which investigated not just the cardiovascular endpoint but also the renal safety. Now, the renal safety of linagliptin in more than 8,000 patients were definitely proven in the Carmelina, and then came the Carolina. So Carolina was almost a long term, that is 6 years outcome, but it established both the cardiovascular as well as kidney safety profile of linagliptin. So if you use this drug in a type 2 diabetes mellitus patient for a long duration time, that is say 6 years or even more, then you tend to give benefit not just in terms of blood sugar control, but in terms of better cardiovascular protection and better renal protection as well. So the more comprehensive data for linagliptin was in clinically relevant patient population, patients who had higher risk. There is no rise in risk of heart failure, because we know in SABR-TIMI trial with saxagliptin it was found that the heart failure hospitalization was increased. So, but this drug conclusively proved that there is no additional cardiovascular risk. And what was taken for granted was it has a proven renal safety, because it could be used even in advanced CKD. And we know that SABR-TIMI with saxagliptin had significantly increased adverse events, and similar was also with Examine, which used allogliptin. Of course, the trial with sitagliptin, that was TICOS, was neutral. At least it's proved that sitagliptin was safety. But when you think of Carmelina, you find that the dot has shifted to the left of the center. That means it definitely favors the use of linagliptin. So that is a very substantial input so far as using a DPP4 inhibitor is concerned. And that's why when we look at the European Society of Guideline 2019, in patients of diabetes or pre-diabetes with cardiovascular disease, there is a very clear-cut mention about SGLT2 inhibitors like empagliflozin, canagliflozin, and dapagliflozin associated with lower risk of heart failure hospitalization. So it has been clearly mentioned that you have to favor them with using them as a class 1 level A recommendations. And with DPP4 inhibitors, specific mention is about sitagliptin and linagliptin, because they have been found to be cardiovascular safety. And there is a black box mention about saxagliptin because it increased the heart failure hospitalization. So if we compare and combine the outcome of Empa, which used empagliflozin, and Carmelina, which used linagliptin, we find that the data is almost about 14,000 to 15,000 patients. And in such a robust patient population, we have found there is a substantial reduction of kidney endpoints as well as heart-related endpoints. So from triumvirate means people used to think about three important attributing causes of development of diabetes to current concept of octet means 8 different aspects in which the diabetes may be caused. And so the target should be multi-pronged, and that's why the combination is preferred, which we have stated from the beginning of our discourse. So effective treatment of type 2 diabetes requires multiple drugs used in combination to correct multiple pathophysiological defects, and that is why the concept of going for combinations. This is the famous ominous octet, and that we find that different types of mechanisms are ultimately leading to hyperglycemia. So if we use different class of agents, then hyperglycemia may be countered by different type of agents. Like DPP4 inhibitors are acting on glucagon secretion, whereas SGLT2 inhibitors are acting on glucose reabsorption. If we are using these two drugs, then we are deriving benefits from these different ways along with these different ways. So that's why overall results from a combination are substantially better than using one drug or a monotherapy. So the ADA recommendations which come out in 2020 has pointed out a very important thing. The absolute effectiveness of most oral medications rarely exceeds 1%. So initial combination therapy should be considered so that our ultimate aim of providing better glycemic control with better long-term complication prevention is achieved. So for that, we can think of combining DPP4 inhibitor and SGLT2 inhibitor, which have insulin independent mechanism in SGLT2 inhibitor and insulin dependent mechanism in DPP4 inhibitor, along with glucagon related benefits here in DPP4 inhibitor, and DPP4 inhibitor having one important advantage of being weight neutral, whereas SGLT2 inhibitors in fact have a weight loss property. That is why both having an advantage of minimal to no hypoglycemia can prove to be a very good and excellent combination. And another very important thing is both these drugs have been proven in landmark trials to be having their cardiovascular safety as well as renal safety. So when we think of cardiovascular safety with SGLT2 inhibitor, empiric outcome is there. When we think of the renal safety with the DPP4 inhibitor, the Carmelina trial is there. Carmelina and Carolina trials are there. So we can get dual benefits when we combine the SGLT2 inhibitors with DPP4 inhibitor. And one important thing is they can be given to both drug naive patients, means a person who has not received any anti-diabetic drug, or can also be given to patients who have already been started on metformin. So ultimately, what is the outcome? We achieve our glycemic targets early, and once we are able to achieve that, we can sustain it for a longer duration of time. So early achievement of goal and durability of action, because you may aggressively reduce the blood sugar, but if you are not able to maintain it, then you land up with something called as glycemic variability. And we know that a high glycemic variability is adverse in producing complications. So with this combination, we are achieving the glycemic target, and we are also having a less glycemic variability. And another important thing which has been suggested is they can be provided in a fixed dose combination. So what is the advantage of a fixed dose combination? It improves the compliance of the patient. If you ask a person to take two different tablets, then the compliance is definitely less than asking somebody to take a single tablet. So fixed dose combinations. And a very important thing is it has been found that the genitourinary infections which are increased with SGLT2 inhibitors are in fact reduced when they are combined with DPP4 inhibitors. So the adverse effect profile is also favorably reduced. So that's a very important thing. So when you have a simultaneous combination of SGLT2 inhibitor and DPP4 inhibitors, then you have a lesser incidence of or a lesser risk of suffering from a genitourinary infection. So what are the benefits of Empa and Lina combination? If you are going to provide in a fixed dose formulation, obviously there will be glycemic benefits. So HbA1c reduction will be definitely better because both the drugs are very good anti hyperglycemic properties. But besides that, the other benefits are really significant. That is, they have proven cardiovascular and heart failure related benefits. So the incidence of hospitalization to heart failure is going to come down. And the second most important benefit is they have renal protective outcomes. So your decline of EGFR, or they tend to provide a better protection of preservation of nephrons. And along with that, two very important side effects. If you are going to treat an obese patient, this is an excellent combination because it achieves weight loss. And the risk or the apprehension of urinary tract infection is also reduced when we combine the SGLT2 inhibitor with DPP4 inhibitor. And with fixed dose combinations, you can have a convenient once daily dosing. So these are the most important advantages of this excellent combination. And our highlight is not about just bringing down the blood sugar, because we have told very little about reducing the blood sugar, because that is expected to happen. But besides reducing the blood sugar, the other benefits are really startling, and that will induce us to go for this combination in patients who have either a higher risk of heart disease or a higher risk of kidney disease. Thank you for your patient hearing. Yes, we can ask the audience to unmute and ask their questions, or if they put their question in the chat box also,
They
we
will
can take.
put their question in chat box.
Yes, yes. That,
Sir, I think there are no further questions. So, with your permission, shall we conclude this session?
I think there is one question from Dr. Sham Narayan.
Yes.
Should Empalina FDC given to renal patients? Now, that's a very important question. Now, one important concern, which may be, because we know that linagliptin is excellent safety profile in renally compromised patients. So it can be given to patients of CKD who are in advanced stages of renal failure. Like, if you are not comfortable about using other DPP4 inhibitors in stage 2 and above, you can use linagliptin there. So linagliptin can be used in stage 3A, stage 3B, and other advanced CKD patients. But the question is whether we can use combination of empagliflozin with linagliptin. Now, the important issue is empagliflozin is something, it belongs to a group of SGLT2 inhibitors which are known to increase the total urine volume. So we are using diuretics in patients of advanced CKD. Now, the SGLT2 inhibitors are currently being termed as smart diuretics. Smart diuretics intravascular circulating blood volume, but they also bring down the interstitial water content. That is why they are excellent diuretics. In other words, they are smart diuretics. So if you use a combination of linagliptin with empagliflozin, in linagliptin you are providing renal safety, and in empagliflozin you are providing renal protection, which is in fact advantageous. That is why a combination of empagliflozin and linagliptin has also shown to be of definite benefit in patients who have their EGFR reduced, let's say less than 45 ml or even less than 30 ml. So that's why you can use them in renal patients. Another question we have, which renal stage it should be prescribed? Yes, you can use them in stage 2 and stage 3A, even stage 3B as well. Another question is, if the EGFR is less than 45, is it safe to? Yes, they have been tried up to a level of 30 EGFR. So if someone has EGFR less than 45, you can also use Empalina combination. And one thing somebody has to be careful. If a person is volume depleted, remember, if a person is volume depleted, increases the risk of ketosis. So if a person is not volume depleted, even if he has renal compromise and his EGFR is less than 45, then we can also give them a combination of Empa with Lina. In fact, two very important questions were put forth by, and let us not forget, the important cause of death in these patients are cardiovascular endpoints. They do not die due to renal failure, they die due to cardiac endpoints. So if you are using a drug that provides definite cardiac benefit, then ultimately the risk benefit ratio, whenever you want to give a drug to a high risk patient subset, you have to assess the risk benefit ratio. Here the risk benefit ratio is in favor of benefit. That's why a lower amount of risk can be overturned by a higher amount of benefit.
Sir, I think there are no further questions. So, with your permission, shall we conclude the session?
Yes, of course, you can.
Okay, sir. So, on behalf of organizer, I would like to thank you for your insightful and educative talk. Thank you, sir.